Hello, good evening, everyone. This is Ashley DePriest. I am the president for the Southeast Chapter Society of Critical Care Medicine. We want to thank everyone for joining us this evening for this live virtual lecture. We have a few announcements to get started with, and then I'll introduce our speaker. But first, we'd like to start our meeting like we start all of our meetings, which is by reading off our mission and vision. So the mission of our chapter is to emulate SCCM's mission, which is to secure the highest quality care for all critically ill and injured patients in the Southeast region by providing educational and research opportunities, as well as promoting multi-professional collaboration. Our vision is that all critically ill and injured persons in the Southeast region will receive care from a present integrated team of dedicated trained intensivists and critical care specialists, as well as inspire new leaders and providers of critical care in the region. So to get started with a few of our announcements, we have our slide deck here, which is usually playing in the background for everyone, but since we're doing things virtually, I figured I'd just go ahead and go through these slides. Just a reminder, tonight we are live tweeting the meeting, so we'll have some of the key points from tonight's lecture live on Twitter, and you can always go back and visit those and see those. You can search for the hashtag SCCMSE or follow us on Twitter at SCCMSE. And also check us out on Facebook. You'll be able to find a lot of our information and activities and things that are happening throughout both of those platforms. We also have, in addition to our main major lectures, we have what we call our bite-sized lecture series, which is typically a multi-professional panel of speakers that each get to deliver a 10 to 12 minute, what we call bite-sized lecture on a complementary topic, and it results in a full hour's worth of multi-professional education. This is a great opportunity for anyone who is looking at regional level speakerships. So you can reach out to Susan Smith at uga.edu if you have any ideas for topics, or if you have 4 folks that you'd like to get together with and give a presentation, just reach out to Susan and she can get you set up with that. Just a reminder, if you're not already a chapter member, it's very easy to sign up. You can go to the main SCCM website, sccm.org/membership, and sign up. You do not have to be a national member in order to be a Southeast chapter member. And here you can see all of the wonderful membership benefits, and you can also see these on our website, which is at sccmse.org. Just a little bit more about our chapter. Again, you can find out more about us on sccmse.org and our chapter leadership here. Another program we have is our mentor-mentee program. Again, more information about that on our website. This is a very interesting way of doing mentorship in critical care, which really focuses on multi-professional collaboration. So we're looking for folks who may be looking for mentors in other disciplines. For example, if you are a dietitian and are interested in learning more about pharmacy, you can request a pharmacy mentor to learn more about pharmacists and pharmacy work. Or it could work the other way around if you're interested in providing more information for others. So for example, if I'm a dietitian and I want to provide more mentorship to others about nutrition, I can sign up as a mentor or a mentee. So check out our website again for more information on that program. And a quick reminder, you can always support the chapter through Amazon Smile if you're making a lot of Amazon purchases. I think a lot of us in quarantine right now are making a lot of Amazon purchases. So support the chapter at smile.amazon.com and type in Southeast Chapter Society of Critical Care Medicine, and you can contribute some of your shopping towards our chapter. Another announcement. So we have the Barbara Mclean Contributions to Critical Care Nursing Award 2020. We did postpone this award. It was initially part of our Critical Care Awareness and Recognition Month earlier in the year, and it was postponed until later on. So we are reopening up for nominations on that. So if you have a nurse, specifically a bedside nurse that you think models collaboration, contribution, evidence-based communication, and collegiality, please reach out to the chapter. You can get a hold of us at communications@sccmse.org, and we can get you some more information about making that nomination. And before we introduce our speaker, just a reminder, our next upcoming meeting is November 10th, 2020, featuring Dr. Lewis Kaplan, the Society of Critical Care Medicine president, who's going to be talking about viral leadership. Again, this will be a virtual event, so look for more information either on our social media or in your email inbox. CE instructions are here for tonight. Take a picture with your camera there, your smartphone, take a screen grab. We can also email these out for those that are needing the certificates. But there is your link to the survey, and certificates will come from communications@sccmse.org. Reach out if you have more questions about that. So without further ado, I'll introduce tonight's speaker, which is Dr. Aaron Cook. Aaron Cook is the Clinical Coordinator of Neuroscience and Pulmonary Critical Care Services at UK Healthcare in Lexington, Kentucky. He's an Associate Adjunct Professor at the University of Kentucky College of Pharmacy and the PGY1 Pharmacy Residency Director at UK Healthcare. His practice is focused on caring for patients in the neurocritical care area, particularly those with stroke and traumatic brain injury. Dr. Cook is active in neurocritical care nationally as chair of the Pharmacy Research Group and the incoming chair for the pharmacy section within the Neurocritical Care Society. He is also co-author and presenter of the Neurocritical Care Board Certification Preparatory Course material for the American College of Clinical Pharmacy. Dr. Cook is active in neurocritical care research and scholarship with particular interest in pharmacokinetic and pharmacodynamic changes in response to neurological critical illness. So please join me in welcoming Dr. Aaron Cook, who is speaking tonight on treating intracranial pressure elevation in neurocritical care.
Thank you, Ashley, very much. I'm going to work on sharing my screen here. As I'm doing that and getting prepared, I'll just be quiet, and you all can't make any noise because you've been silenced, but just kind of we'll do just a quick moment of silence for all of our colleagues that may not be able to be on this call right now because of the hurricane going through a lot of our southeastern states. So hopefully you know that our thoughts are with you, and stay safe, and we hope that this passes quickly with the least amount of damage possible. If you cannot see my slides, Ashley, let me know. I have them up and I'm sharing. Is that working? All right.
Yes, looks perfect.
So I'm going to talk about intracranial pressure management, and I may use cerebral edema and intracranial pressure, or ICP, interchangeably through this, and I'll explain a little bit why, what sort of the differences are and why I might do that. But Ashley, I thank you very much for quite a mouthful of the introduction, and I really appreciate being invited to talk on this topic. It's been something that has been a big part of my work life for the last couple of years, really, as we have gone through creating guidelines on the initial management of ICP. And I'm going to talk a little bit about those, as well as just some of the drug information related to some of the drugs that we might use. So we're going to talk about the relevance of ICP and cerebral edema after neurologic injury. I'll also talk a bit of compare and contrast some of the agents that we might use, especially osmotherapy agents. I'll talk a little bit about some of the highlights of the guidelines and specific questions that we thought were really important, and also talk about some of the safety parameters related to osmotherapy. So a couple common terms and definitions. ICP, or intracranial pressure, is the measured pressure in the brain. Cerebral edema is typically more aligned with swelling in the brain. And the reason why I may use these interchangeably is certainly patients with cerebral edema may have elevated ICP, but in many patients you may not have a catheter or anything to really tell you what that ICP value is. Certainly within cerebral edema, it can be very heterogeneous. It could be vasogenic edema, like you might see with some hemorrhages or tumors. It could be an osmotic edema, or even a cytotoxic edema, like we see in secondary injury after traumatic brain injury or TBI. Osmotherapy is a hypertonic concentration of a drug, which creates an osmolar gradient. And most commonly, when we talk about osmotherapy, we're talking about mannitol and hypertonic sodium solutions. I will differentiate at times between hypertonic saline, which I'm abbreviating HTS. That's typically 3% or greater of sodium chloride. But sometimes I'll say hypertonic sodium solutions, not just because I want to be generic, but there are other salts other than chloride that we use with sodium. And I want to make sure that those are addressed because some of those are specifically used in studies that we'll probably talk about. Common salts that you may see are sodium acetate, sodium lactate. We'll talk about one or two others as well. Okay, so with ICP, there's numerous reasons to suspect elevated ICP or cerebral edema. It's pretty well elaborated in the brain injury guidelines, the Brain Trauma Foundation guidelines on when you might consider putting in an ICP catheter in the context of trauma. And very broadly, my talk isn't about when to put a catheter in because that's, as a pharmacist, that's not my role, thankfully. But typically it's when your neurologic score is poor, like GCS less than 9. If on scan you have diffuse cerebral edema, if you see papilledema on ophthalmologic exam, other pupillary changes may tip you off that the patient has elevated ICP. May just be the neuro exam and the mechanism. You know that a patient's had a trauma or some sort of acute event like a stroke that would make you suspect that. So there are a lot of clinical reasons to suspect elevated ICP, as well as when you put that catheter in, knowing what that number is. So there's a lot of different ways. Your centers may use one method preferentially over the other. At my facility, we use primarily the ventricular catheter, which is pictured in the middle here. It's a catheter that's inserted through a burr hole in the skull and placed in typically the frontal horn of the lateral ventricles. But certainly you can see parenchymal or intraparenchymal catheters, which may be called one brand is called a Codman. Also Lycox is another type that not only transduces the pressure, but also gives you oxygen, brain tissue oxygen readings as well. And there's a variety of others that you may see that can tell you what the pressure is inside the brain. These are all inserted by bedside procedures under usually sterile conditions and can be kept in for any number of days to even weeks, provided everything is going well from an infection standpoint with the catheters. There's numerous problems with the catheters. There's disagreement on what the right place is to put some of these things, what the right values are to treat, and all of that. So just like everything else in critical care, we can get a number pretty readily, but then what to do with that number and how meaningful the number is, sometimes it's a little bit under debate. But in general, we think that intracranial pressure is important because of the Monroe-Keeley doctrine. And so on the left, I have pictured the skull with sort of in gradations for the amount of CSF and cerebral blood volume, which is CBV, that make up what's inside your cranium. Tissue makes up the bulk of most of what's inside our cranium. If something is as depicted in figure 2, or panel 2, that little brown spot, if you've got something that's taking up extra space in the tissue, it will eventually get to the point where the capacitance in your brain is not able to buffer that increase in volume, and your pressure goes up, which is depicted with the black line as you go from panel 3 to 4. Sometimes that's an acute hematoma or stroke. Sometimes that's a brain abscess or a tumor, which may occur over a little bit more period of time. As you can see, the brain tissue really doesn't have much of a chance to move anywhere unless you have herniation. So what ends up happening in your brain is that the blood volume and the CSF tend to be the compensatory measures, and there's limits to that. So that's when you see the pressure go up. So as I mentioned, there could be any number of reasons for ICP elevations, including brain swelling. That tissue swelling is part of that Monroe-Keeley doctrine. You could see osmotic edema, so maybe extracellular space may become larger and sort of third spacing, if you will, in the brain after trauma or other situations where you may have blood-brain barrier breakdown or extra protein floating around in the brain, like in meningitis. Certainly, hematomas are sort of a classic reason, an acute reason for elevated ICP. It's not really that easy. It's nice to think about, well, it's just a number and it's kind of homogeneous, and if it's over this threshold, then we should treat it. But there are different phenotypes for ICP and edema that exist among patients. And so it's being shown now that there are certain sort of time courses that patients will go on, and it's not easily predicted at this point what your phenotype is going to be until you start exhibiting it. But there are definitely some specific phenotypes that we see with intracranial pressure, some that are more acute, some that are more refractory, some that occur after the period of 3 to 4 days, some that dissipate after 2 or 3 days. Much of this may be related to genetic polymorphisms related to inflammation and repair in the brain. And a lot of those polymorphisms haven't really been well elaborated on yet, but certainly a lot of the rest of it depends on the degree of your injury. Pre-hospital factors, like did you have a prolonged extrication and you're hypotensive or hypoxic, may exacerbate ischemia. So there's a lot of different factors that play into ICP and the pathology. So say that primarily because I really believe that saying that a patient has elevated intracranial pressure, you can have 3 patients in 3 different beds in your unit that have intracranial pressure monitors, and their reason for ICP elevation may be different in each case, and the treatments that are required may actually be different in each case as well. So we're kind of in a weird spot with ICP monitoring. We know that ICP elevations are bad. They're associated with poor outcome. We have good strong retrospective data on that. And I think clinically we observe that in a lot of our patients. But ICP monitoring is not always associated with good outcomes. So sometimes knowing what the number is doesn't really help you. Specific for treatments for ICP, none of the treatments that we're talking about today have been shown to improve outcome for patients with elevated ICP. It may lower the pressure, but it probably doesn't improve outcome. No one's shown it. There are risks to ICP monitoring, for sure. And you may not always have access to that sort of measurement. There may be patients where it's not appropriate, or maybe in an environment where you're not able to do that. And then, as I mentioned before, the pathology may vary with etiology and other factors as well. So I don't think that thinking about ICP, treating ICP should be sort of homogeneous in mind. And I think a perfect example of this is sort of the first study on the upper right, the trial of intracranial pressure monitoring in traumatic brain injury. This was a study by Dr. Chestnut and colleagues, which they did in Central and South America, where they randomized patients to get an ICP catheter versus no catheter. And they just used imaging and clinical exam to guide sort of presumptive therapy for elevations in ICP. There were no difference in outcomes, whether you had an ICP catheter or not. And so I don't know that that study necessarily means that we shouldn't put catheters in patients, but it did call into question a lot whether we should do that in all patients, whether the thresholds for treatment that we use commonly are correct. And it really, I think, turns some people on their head a little bit and thinking, well, this is something that I feel like is tried and true, but in fact, it didn't bear out in a well-done clinical trial. But on the bottom left, you see sort of the opposite end of the spectrum, where we're doing more invasive monitoring, more numbers by using this brain oxygen optimization and TBI, or the BOOST study, And this is a study that used sort of multimodality monitoring to get more information, to get ICP, to get brain tissue oxygenation and other measures that others use microdialysis to look at lactate pyruvate and metabolic measures and stuff like that. And there's definitely promise in some of these studies that suggests that knowing some of these things can help you understand what's going on minute to minute. In reality, ICP is a very global measure. In some respects, it's like what you might get with SVO2 and sepsis. It tells you that there's a problem, but it doesn't necessarily pinpoint where that problem is. And some of these other catheters that show brain tissue oxygen monitoring and that sort of thing may help us pinpoint things a little bit better. But we've got one study that says no effect for traditional monitoring. We've got one study on the screen that says if you do way more of sort of a souped up strategy, it may be helpful. And we're right in between somewhere, and I don't know exactly where we are. But for today, let's assume that reducing an elevated ICP or cerebral edema is a pretty reasonable treatment goal, particularly compared to just permitting it to stay where it is. I think we kind of know what happens if a patient's blowing a pupil and you do nothing, something terrible is going to happen in that patient. And so I think it's a reasonable supposition that we should treat it. I think a reasonable goal, at least at first, to keep is an ICP less than 20 for most patients. That probably varies based on the patient and their treatment response previously, but I think those are probably reasonable suppositions for today. So I'm going to talk a little bit about the guidelines that have been published recently through the Neurocritical Care Society. I was fortunate enough to be one of the chairs for this working group, and we really endeavored to look at the acute treatment in cerebral edema. So we did not really focus a lot on inducing pharmacologic comas. We did not focus on decompressive hemicrania. We did not talk much about targeted temperature management or hypothermia. One, because we felt like some of those may be a bit out of our scope, and others, there are other recent guidelines that we felt like address those pretty readily. So this guideline is more focused on the acute treatment, and really it started out as an osmotherapy guideline and sort of expanded to include other things. But we really wanted to hone in on specific disease states. So really honoring that thought that a patient with elevated intracranial pressure who has TBI is not the same as someone who has a subarachnoid hemorrhage or an intracerebral hemorrhage, and the pathologies may indeed be different. We wanted to look at ICP response versus neurologic outcome and improvement in neurologic outcome, because we were not totally sure that effectively treating the ICP is actually going to help the patient do better than not. We wanted to look at safety parameters, because we're very focused on efficacy and can we treat this elevated ICP, which we all feel like is a life-threatening situation, but can we do it safely, and how do we do that? And then we really wanted to hone in on sodium targeting, having a specific sodium threshold that we might try to employ in some of these neurologically injured patients, and explore the literature in that area as well. So I'm going to talk a little bit more about the guidelines a little bit later, but first off, let me see if I can launch this poll. All right, so the poll is, what is your institution's preferred osmotherapy option? And I think probably you can see the bar graph on the screen. Okay, this is good. It's slowing down a little bit, so I'm just going to close it. But it's about half, 3% sodium chloride, and then about a quarter of the responders said either mannitol or 23.4%. Nobody said other. So that's good. Okay. Thank you for responding to that, for those who did. We're going to move on to talk about some of these osmotherapy options. So, here I just have sort of the equiosmolar doses for some of the more common osmotherapy agents. Of course, 20% mannitol, 3% sodium chloride, 23.4%. sodium chloride are all options that you voted on. And you can see here the main difference with these is the osmolarity and the volume, right? Really the amount of 23.4% sodium chloride that you need is pretty low because it packs quite a punch. When you think about your normal serum osmolarities, 280, 290, and this drug's 8,000. It's very concentrated. So I think just great care needs to be had with these because there are so many different concentrations. There are different concentrations in the studies that have been used. And so I think practically, clinically, you have to have some oversight with regard to making sure that ordering is appropriate, that when prescribers put these orders in, that the volume is reasonable. And when we're pulling these out of our automated dispensing cabinets, that we have safeguards to make sure that we're selecting the right product, because it's a situation that could be fraught with error with different concentrations, especially in areas that maybe don't use them all the time. But in reality, I think for the most part, these are all pretty interchangeable. We'll talk about some variances with that potentially. I think these are all pretty interchangeable. One thing to keep in mind when you evaluate the literature in this area and that we noticed is that not all studies, they may have even randomized patients where you get mannitol, you get hypertonic saline. They may not have even used the osmolar dose. So it's apples and oranges. So when you're reading studies on these agents, you really have to think about, is this an osmolar dose? Is this the same osmolarity that I'm giving the patient with mannitol versus hypertonic saline? So if it's not the same dose. But another drug that I have on here that I've really tried to coach myself to do better, I used to always call it bicarb, but it's sodium bicarb, and it's hypertonic, and it's everywhere in your hospital. So if you get in a pinch and you don't have any of these other agents available, and you're in a unit that maybe doesn't see patients who could have an acute neurologic decline, but you have a sort of an acute stroking patient or something like that, who you suspect has cerebral edema or intracranial pressure issues, you can just grab some bicarb. It's about 1 ml per kilo is the osmolar dose, to 0.5 gram per kilo of mannitol, or a similar dose of 3%, and it's widely available. So nice pearl to use bicarb if you have to, if you're in a pinch. Okay, so how these osmotherapy drugs work. This is sort of a chemistry sort of example, but if you've got this semi-permeable membrane in the beaker on the left, the osmolarity in the left beaker on the right side is a little bit more dense. That's your brain. It's not as high on the left side of the left beaker. That's your serum. And if you increase the osmolarity, in this case, it also reduces the volume, but you don't see the volume squeeze over. If you increase the osmolarity in the serum, what's going to happen is water is going to move from the brain into the serum and cause a shift, sort of a dehydration, so to speak, of the brain. And so those osmotherapy particles, the mannitol or hypertonic saline at high concentration, is going to pull water from different tissues. In much the same way you might imagine albumin does it for oncotic reasons. But that's one of the ways in which it works, and it does appear to be pretty effective at dehydrating the brain. Another reason that osmotherapy works pretty quickly is the principles of cerebral autoregulation. So if you start at the top with increase in CPP, or cerebral perfusion pressure, should cause vasoconstriction. Vasoconstriction should reduce blood volume, which, as you'll recall in the Monroe-Keeley doctrine, blood volume is one of the aspects that makes up your ICP in the Monroe-Keeley doctrine. So reducing blood volume reduces your ICP, and then that further increases your CPP and so on. So when you give an osmotherapy agent, what you're basically doing is rapidly increasing blood flow, right? Rapidly increasing perfusion. Any bolus does this, particularly one that will carry with it so much other fluid. It's a very effective initial fluid bolus. Well, that's going to cause an intense vasoconstriction, or you can think about it in terms of venoconstriction, probably more appropriately. If it were arterial vasoconstriction, it would potentially be a problem, right? I mean, you would have ischemia, but we actually see improvement in perfusion indices when you give these drugs. So it's probably more on the venous side, which, as you know, the venous side is sort of passive. And if you can wring out that blood volume on the venous side, then that's really going to dramatically reduce your cerebral blood volume. That's incidentally the reason why we elevate the head of the bed for brain injured patients and patients with stroke. If they're laying flat or in Trendelenburg, then their blood volume is going to increase, right? Because they're laying flat. Gravity isn't getting that blood volume out of their brain. So this is another mechanism by which the osmotherapy agents work. As it turns out, this probably is a little bit more transient, probably happens and sort of dissipates over the period of the first 15, 30 minutes. The osmolar gradient depicted on the left is probably a little bit more of an appropriate longer term mechanism, usually 4 to 6 hours. So one situation that we have right now is sort of thinking about things that exacerbate intracranial pressure, and one of the things that is commonly identified is hyponatremia. And incidentally, most neurologically injured patients have some predilection for hyponatremia to begin with. And certainly patients with acute hyponatremia can exhibit elevated ICP. So I'm just going to say some things, and then I'll show you where the evidence is. I think treating hyponatremia, real hyponatremia, less than 135, is likely to have an immediate beneficial impact on the ICP for many patients, because we know that hyponatremia will cause sort of an influx of water into the brain, and that will exacerbate your ICP. Now, the question really is, if you're not hyponatremic, will driving your sodium up help you in any way in reducing your ICP? And I'll talk about some of the data with that, but I think the jury's still out on that. I'll show you this picture from the Wells study because for a couple reasons. One, there are squared for the relationship in change in serum sodium values, and the relationship to the change in ICP is really poor. There's very little association in their study of brain injured patients with the change in sodium and change in ICP. So there's about 98% of the change in ICP was explained by other factors than sodium. So treating hyponatremia is probably helpful. Treating normonatremia and really is more better. I mean, you tell me, in critical care, how many times has more actually been better? It's not that often. So to me, the jury's still out on this. We'll talk about the literature as we move forward. Okay, so I'm going to focus on some specific recommendations that we have just to kind of hone in on some of the guideline things. One is the classic question of mannitol versus hypertonic saline. And then I'll talk about sodium targeting versus giving hypertonic saline boluses when you're symptomatic. And we'll talk about safety, as I mentioned before. So before I move into that, I want to talk a little bit about sort of how we did the guidelines, just so it's not me trying to convince you. It's not just me, it's this awesome working group that we had. Very multidisciplinary, people from every end of the country, as well as some international members and senior members, junior members. It was really a very diverse and really fun group to work with. Everybody had their assignments and contributed extensively. I'd be remiss if I didn't call out a couple major players in this. Morgan Jones, who did a lot of the table work at the end of the article, as well as a lot of the writing in his section. Karen Hirsch, who helped guide us through evaluating the literature and doing it in a rigorous way. And then my co-chair, Lori Shutter, who is amazing and really helped, especially as we sort of started to memorialize some of our discussions in writing, was amazing. So really cool group. So we did sort of the normal guideline process where we had a librarian perform an extensive search of the medical literature. We only pulled stuff that was published in English, and we asked 16 different PICO questions, and I'll kind of show you what we did there. We included some case series, but only if more than 5 individuals were reported who had that specific disease state that we're looking for. And you'll see what I mean in a second. All these references were uploaded into this online portal for data abstraction. Basically, everybody screened articles for general inclusion. For some reason, my section, I had a bunch of articles on like invertebrates and stuff like that, so I had to screen a lot of those out. So we did sort of the preliminary screening, one person, and then everybody was assigned at least 2 of the PICO questions, read everything, and then they sort of scored and rated the bias and the benefits or merits of each study with at least 2 different authors. And in the case where the 2 authors didn't necessarily agree, that's where the co-chairs sort of stepped in and resolved some of those conflicts and helped. So, you know, this part of process, you can do a lot of it on your own time and through teleconferences. And of course, this was pre-COVID, so Zoom was kind of still something that we just did for this, you know. But we did have 2 live meetings, one in Boca Raton, which was amazing, and then one in Chicago, which was curtailed by a snowstorm. So we had both ends of the spectrum on that. But I'm not going to bore you with this table necessarily. It's more for your reference, but we asked questions about the different disease states, which you'll see kind of on the left. Subarachnoid node hemorrhage, TBI, intracerebral hemorrhage, acute ischemic stroke or AIS, meningitis as well, and hepatic encephalopathy. Sort of again honoring that concept of not all of these patients are the same, right? Patients with meningitis who have ICP elevations may have different response characteristics or needs than patients with TBI and vice versa. But also take into account the initial search, which often was a pretty wide swath of literature, and then the number that we were able to include in the end. TBI was pretty well represented, but a lot of the rest of these topics were just extraordinarily small. So, and you'll see that a lot of what we were able to include is not highly rated from a scientific standpoint. So just goes to show you there's a tremendous amount of work, good work that still needs to be done in this area so we can be more sure about what we think is going on. Here you see some of the safety things as well as hepatic encephalopathy. We also had a non-pharmacologic question as well that sort of highlighted aspects like hyperventilation and that sort of thing. Okay, so if you're not familiar with the grade criteria, we rate things either high, moderate, low, or very low. And you can see sort of the characteristics here. High are the strong randomized clinical trials, well-done meta-analyses. Those are sort of the top of the pyramid for the grade criteria. And high really means that high and maybe moderate means that not much is likely to change your mind. It's unlikely that a study's going to come out that's powered that would change your mind on a given topic based on what's already been published. But moderate is randomized clinical trials or meta-analyses like a high, but with maybe some potential for bias, or strong retrospective controlled studies that account for different bias. And then as you go down, it's lesser numbers, maybe more heterogeneous patient populations with low and very low, less control between the exposure and the control cohorts and that sort of thing. So, and then when we made recommendations that were either strong or weak or conditional, or we made some good practice statements. So a strong recommendation is that confidence that the desirable effects of following a recommendation outweigh the potential undesirable effects. And that's for virtually every patient. Whereas a conditional, which is what we call ours, conditional, we're not confident that the desirable effects of following that recommendation outweigh the potential undesired benefits. The way that I think about it is there are conditions where what we're recommending is the appropriate thing. But there are conditions where it's not. And that's hard when you're doing a guideline, and if you're somebody who's reading the guidelines saying, just tell me what to do. Conditional recommendations are not all that helpful because we're suggesting things. We're saying, well, it may be helpful. But if there's nothing definitive in the literature, then it's not responsible to make a definitive statement. And then we had some good practice statements that basically these are things that are important but not appropriate for rating. So some of the good practice statements that we had were related to, well, how often would you consider monitoring sodium and chloride in an ICU patient where you're worried about hypernatremia or hyponatremia and that sort of thing? Okay, so I'm gonna get on my soapbox for a minute. It is in the guideline. It's probably one of the things that that bothers me the most about talking to people about guidelines. So just because we wrote something in this guideline doesn't mean that you have to follow it. Now, strong recommendations with high grade evidence, like aspirin for MI, you should do that, right? I don't think there's much question in that. But just because it's mentioned in the guidelines doesn't mean that it's something that you have to do. In particular, if it's a conditional recommendation with low or very low quality data. It's the way that the literature leans, and it's the suggestion that the guideline committee is giving you, not just ours, but every guideline that you read, there's going to be some areas where the literature is weak, and they're going to give you weak or conditional recommendations. But that does not mean, just because it's in the guideline doesn't mean you have to do it. So a lot of these things, unfortunately, are not, that I'm going to talk about today, are not really founded by really strong evidence, and they're not strong recommendations. So they are in the guideline, but they're not necessarily things that you have to do for every single patient. There are conditions where it's not appropriate, and it's up to you to kind of figure out when those are. We do talk about that a little bit in the guidelines for some of these conditions, but not all of them. Okay, soapbox is done. Don't tell me it's in the guideline. Tell me the strength if you tell me it's in the guideline. That's the important. Okay, so let's talk about hypertonic saline and mannitol, which is best. There are numerous studies. There's heterogeneity abound in this population. Some of the studies randomized subjects to one agent or the other. Some randomized to start with one of the agents, but then alternated to the other. Almost all the studies were mixed neurocritical care, which is a whole nother pet peeve of mine. Blood in the head. Traumatic brain injury is not the same as intracerebral hemorrhage. Subarachnoid hemorrhage has a totally different illness profile with vasospasm and everything over the course of 2 weeks than does a brain injured patient. But lumping them all together in a study as a neurocritical care population may or may not be appropriate in a lot of these cases. So we downgrade a lot of those studies for potential bias for that reason. A lot of the early hypertonic saline studies, especially from Europe, also explored combining it with hetastarch and other colloids. And so that may not necessarily be as apples and oranges necessarily to some of the other studies that we have. And almost none of the studies talk about the timing and the course of illness. So does the response to osmotherapy change between day 1 and day 4? It probably does. It may depend on what phenotype. We didn't even really know to think about that during most of these studies. But that really wasn't even talked about. And when you think about other things, like if you're talking about sepsis and you're telling me about somebody's response to vasopressors or steroids or something, and you don't tell me where they are in the course of the disease, it's really hard for me to assess, how that patient's actually doing or responding. It's the same with ICP. And almost none of these were timed to where, oh, they got this dose on average on day 2 or 3. It's very challenging to assess from a practical standpoint. So there are some meta-analyses that have attempted to sort of pull this together, and most of them are quite good. But it's a sure sign that there's not a lot of agreement when multiple groups feel like they need to do a meta-analysis on the same time. One cool meta-analysis that was done was by Lee in 2015. And one of the things that I like about it is they did it by timing. So this isn't day 3, day 4, but they looked at the ICP response for the studies that had this information. The ICP response from 0 to 30 minutes at 60 minutes, at 120 minutes, and overall, just to sort of to give you a hint at, are these patients responding quickly? Is the response somewhat durable? And you can see based on their data that largely it favors hypertonic saline in these patients for having a quick but also a durable response over their time period, which was really 4 to 6 hours. Now, the Mortavesi meta-analysis also favors hypertonic saline. This was from 2012. They included many of the same studies that the Lee meta-analysis used as well, although it was published before. So Lee had a few more articles to work with. But you can see that the number of patients in these groups are pretty small down on the total line, and the number of bad events was also pretty small. So their meta-analysis suggested that hypertonic saline was better than mannitol, but it's still very, very heterogeneous. Almost all these studies had more than TBI, and had subarachnoid and intracerebral hemorrhage patients and the like, and quite small. So these are meta-analyses, which should be the top of the pyramid. We downgraded a lot of these for potential for bias, not by the authors necessarily, but bias just because of the population that was included in the way the studies were done. The Kamel study with a meta-analysis also was really one of the first meta-analyses, and it didn't include all the studies that either of the other two did, and it showed that it probably favors hypertonic saline as well, but you can see here it sort of hits the line of one. So it's challenging to know that, but different methodologies on this meta-analysis as well. It's not including all the more contemporary stuff because of when it was published. So as a panel, we decided that we were going to suggest hypertonic saline over mannitol for initial management of ICP in patients with TBI and intracerebral hemorrhage. We evaluated the same question in subarachnoid hemorrhage and an acute ischemic stroke, and we did not make that same recommendation because the evidence wasn't there. But we felt like in TBI and intracerebral hemorrhage specifically, it wasn't strong. It's a weak recommendation or conditional recommendation, but we felt like that it was enough to suggest hypertonic saline over mannitol. If the literature leans one way in those patients, it leans towards hypertonic saline. We also, with TBI, have ample ammunition to say that mannitol is an effective alternative to hypertonic saline. Just because one drug is sort of picked over the other doesn't necessarily mean that that the other drug isn't a good option. Mannitol is still a good option in these patients. As you can see here, our grade is a conditional recommendation with low quality evidence. And in the case of intracerebral hemorrhage, it's very low quality. So this is not evidence you can hang your hat on. This is our assessment of what was out there. Now, and also in intracerebral hemorrhage, we looked at symptom-based dosing of hypertonic saline, or when you had an elevated ICP versus a targeted serum sodium. So we're aiming for 145 or 150 or something like that. There's no compelling evidence to make targeting serum sodium in intracerebral hemorrhage patients a standard by any means. Almost no studies have really successfully done that or really even identified the appropriate sodium threshold necessarily. So, and neither agent, when we looked at in TBI or intracerebral hemorrhage, is likely to improve the neurologic outcome. It probably does reduce ICP, but it doesn't help the patients in the long run necessarily. So in subarachnoid hemorrhage, we looked at osmotherapy. Hypertonic saline we think is advantageous in subarachnoid hemorrhage because in subarachnoid hemorrhage, we really worry about the patient's intravascular volume more so than many of the other disease states, particularly as the patient goes into their vasospasm window, and giving the mannitol going to force a diuresis, which isn't necessarily ideal in those patients. But there really isn't a lot of compelling evidence to say that hypertonic saline is better. There's just practical advantages that probably place it above mannitol in that population, but there's no studies really that say that. there's conflicting evidence related to using hypertonic saline for maintenance of targeting that serum sodium again. There may be some indirect evidence related to CT perfusion studies and cerebral blood flow related to using hypertonic saline and targeting a serum sodium in that case, but it's all very low quality evidence and not very strong at this point. This is an area, we know a lot of people are using hypernatremia goals and targeting high serum sodiums in a lot of these patients. And we're really hoping that by sort of showing the relative lack of rigor in the studies at this point, that we can get a little bit more strong scientific data in this area to help us know exactly what we're doing and why. In ischemic stroke, we really did not see a whole lot of reasons to recommend one agent over the other. There's conflicting data here with maintenance of a targeted serum sodium, high serum sodium, versus just symptomatic boluses. It could reduce the number of ICP crises in these patients, but with very low numbers, and it doesn't improve outcome. In addition, prophylactic or sort of scheduled osmotherapy for impending cerebral edema is probably harmful. A couple studies that suggest that it's probably harmful. You shouldn't do that, particularly with Mannitol. Again, this is very low quality evidence that if any study was published that had, you know, good clinical rigor in a strong study design, it would probably drive recommendations in the next guideline. So let's dig in a little bit more on this sodium targeted hypertonic saline versus symptomatic bolusing. The way that we approached this was, were you just giving hypertonic saline for elevated ICP, or were you giving hypertonic saline for the purposes of reducing your ICP burden or your ICP crises by maintaining a high serum sodium concentration? So were you kind of pushing them up, or were you just letting the ICP be your guide on when you were giving hypertonic saline? So if you would, kind of wake you up a little bit. So if you can get into the chat, I'm going to run through 4 cases here, and in the chat, I would love for you to type in what your typical sodium goal would be for this patient. And, you know, whether it be 140, 145 to 150, greater than 150, you know, whatever, or, you know, no goal, whatever the case may be at your institution. Not necessarily what you think, but what you would do on rounds tomorrow if we had this patient. I'd love for you guys to put that in the chat. This is one of some of our interactive questions as well. So what's your serum sodium target for this patient? It's a 23-year-old. We just had a motor vehicle collision with this left frontal contusion, and the GCS right now is 464. So if you would just type in the chat what you think the sodium goal would be for that patient the next day or tomorrow if that patient's on rounds. Okay, so Mia says 150.
It looks like we have several responses in the questions section too, if you can see that.
Okay, questions. Okay. 150, great. Okay. Great. All right. Let's move on to the next one, and maybe we'll get more responses on this one. Okay, this is a 47-year-old who had an aneurysm rupture, and you can see this large subarachnoid hemorrhage on the scan here. Right now, this patient's a 464 as well. What would your goal sodium in that patient be? $145 to $150, $140 to $145. Okay. Okay. So a lot of people with goals, so that's good. Okay, let's move on to the next one. Okay, 74-year-old with a right MCA, stroke. Let's say this patient's day 2. hospital day 2. GCS 361 in their left pleugic. So what would your goal be then? Or greater than 145. Okay, 135 to 145. Okay. All right. We'll do one more. Okay. Now here's a right intracerebral hemorrhage patient and a 66-year-old. GCS is 464. Less than 145. Overweight hyponatremia. Okay. Interesting. So I'm seeing some different values from the same people depending on the situation. Some of them are higher or lower than others, which is kind of interesting. So I'd say if I could just sort of hazard a guess and sum up what's in the questions, is most people were aiming in the mid to high 140s for most of these patients. A couple people said their goal would include something as low as 135. A couple people said avoid hyponatremia. A couple people say greater than 150 for some of these as well. So I guess that's kind of what I figured was an extensive amount of variability, number one. And I'm hoping that the people who didn't say anything, either they don't have typical goals or they're not exactly sure because they don't necessarily see all these patients every day. But nobody really said no goal, which is kind of interesting. So I do think that's pretty commonplace now, that sodium targets is sort of a topic of conversation for the care of these patients. So, why are we targeting a higher serum sodium? Well, I mean, normally you have this intracellular fluid under normal circumstances and extracellular fluid. Some of it's in the blood volume, some of it's in the extracellular space outside the cells. When you have hyponatremia, what ends up happening is it expands, but really both of the plasma and the intracellular fluid can expand. But really, what the problem here is the intracellular fluid that expands. This is in a situation where you've already got swelling, right? You've already got an acute ischemic stroke or a brain injury or something like that, where you're having secondary swelling and secondary injury that's causing cytotoxic edema, and in this case, exacerbating that by permitting hyponatremia is a really disastrous situation. So it's a real plausible mechanism for certainly preventing hyponatremia and how that might help you with treating elevated intracranial pressure. Another way to depict it is this sort of classic picture from the New England Journal Review article. It may be a little difficult to appreciate, but when you go from normo to hyponatremia, the brain swells and takes up a little bit more of the space in the brain, and that causes a big problem in patients who are already swelling, right? So those patients have really no reserve for extra swelling that would be related to hyponatremia. So, the rationale is the lower serum sodium concentrations will increase cerebral edema. The thought is that higher serum sodium concentrations should reduce cerebral edema. In fact, when you give hypertonic saline, and that does abruptly change the serum sodium concentration to some degree, usually by 1 or 2 milliequivalents per liter. And in that case, you still see a reduction in cerebral edema or ICP. So the supposition is that a higher serum sodium concentrations reduce cerebral edema. Well, here's the studies that we found that sort of looked at this, and I've got some of the major stuff in red, but you'll see for these 3 that I have listed, they're retrospective with no control group necessarily. These are all TBI studies. Some of them were rather severe and treatment refractory. But in fact, when you look at the first study from 2011, they actually did show that the ICP was reduced to 20 or less after a bolus of 20% sodium chloride, and was maintained with an aggressive infusion with the sodium target of 145 to 150. This is one study with 50 patients. Many of them were contusions, which our NPC patient had. Many of them also had operation and already received barbiturates for coma. The Wells and Paredes and Andrade study didn't show any correlation between sodium and ICP at all. So these aren't really studies that, these are studies that are done in the area, but they don't support targeting higher serum sodium. These other studies also were not very supportive necessarily. The TAN study, the control group was patients who didn't have hypertonic saline. So it was osmotherapy versus normal saline. And then they didn't even evaluate the sodium concentration or the ICP relationship necessarily. So it's a hard study to use, even though that's one of the things that they were hoping that people use this study to support targeting a higher serum sodium, but doesn't really even look at that. The Koenig study in 2008 was more of a case series of mixed neuro patients, and we cite this study a lot in the guideline because it was really one of the first to use a 23.4% bolus and had a pretty good number of patients for a large case series. And they did reverse transtentorial herniation, which is TTH. And that reversal was associated with a higher serum sodium, but they didn't target that. It's just what happened when you gave the hypertonic saline. So this is from the Rockley 2011 study that I referenced before. You can see in this study that there is a little bit of a relationship with ICP and sodium. As the sodium in the orange goes up, the ICP goes down over that period of time and generally stays less than 20. This is the one with the 20% bolus and 20% infusion that was actually supportive. Almost none of the rest of the studies have any kind of relationship with the ICP and serum sodium, much less a picture that looks quite this nice, which I adapted from the article. This is, I think, if it was plausible physiologically, this is what you would expect it to look like. But it's interesting that this is really the only study that shows that kind of relationship that's been published so far. So our suggestion in the guideline was that we suggest use symptom-based bolus dosing of hypertonic sodium solutions. In these studies, there were some other sodium salts like sodium acetate, sodium bicarbonate, rather than sodium targeted based dosing for the management of ICP or cerebral edema in patients with subarachnoid hemorrhage. The targeted hypertonic saline dosing regimens was just very limited and it's very indirect evidence. So we are hoping that with the frequency with which this is used, almost all of you said that in all of these patients that you would have targeted at least mild to moderate hypernatremia, 145, 150, some said greater than 150. And these patients were really hopeful that this weak recommendation, suggestion, and in fact a suggestion away from using this targeted based dosing will be a good call for good research in this area. So right now there's insufficient evidence to support the use of a continuous infusion for the purposes of improving neurological outcomes as well. Certainly we think that controlling their sodium and avoiding hyponatremia is helpful, but pushing them into hypernatremia regions hasn't improved anybody's outcome, at least in these studies. Now, a good practice statement is we do, it kind of goes without saying, and that's kind of what a good practice statement is. Clinicians should avoid hyponatremia in these patients due to the risk of exacerbating cerebral edema. But it goes back to that question, is more better? And at this point, we don't know if more is being better is true. So let's move into safety a little bit. You know, I'll talk a little bit about hyperchloremia in a second, but we'll talk about mannitol first. Classically, mannitol was sort of stated as having an osmolarity threshold of around 320. And if you went beyond that osmolarity threshold, serum osmolarity, then you would be at risk of nephrotoxicity. And it is true that high concentrations of mannitol are associated with nephrotoxicity, but it's not necessarily the serum osmolarity that's the best depiction of that. It's probably the osmolar gap. And you can see this graph here that shows the osmolar gap and the mannitol concentration on the y-axis. Now, the unfortunate thing is mannitol is very, very difficult to assay. Almost no centers in North America have an actual mannitol assay. And so the osmolar gap is the easiest way to do that, to estimate the mannitol concentration. And here you can see the relationship between the gap and the mannitol concentration is reasonably good. So the way that you calculate the osmolar gap, you get a basic metabolic panel or Chem7, and you use this estimated osmolality equation. So 2 times the sodium plus the BUN divided by 2.8 plus the glucose divided by 18. That gives you your estimated osmolarity, which in this case is 312.8. Then you measure the serum osmolarity, which almost anybody can do. In this case, it's 323. You take the difference between the two, and your osmolar gap is 10. So typically, if it's over 55, your mannitol concentration is quite high, probably at the point where it would be more associated with the renal vasoconstriction that we see that causes the nephrotoxicity. An osmolar gap of 10 should be pretty safe. 55, we think, is probably the high value based on some of the limited studies that have been put out there. Now, mannitol's always had sort of a bad rap for nephrotoxicity, but increasingly chloride and hypertonic saline has gotten a bad rap as well, not just in the neurocritical care area, but all across the spectrum of the ICU. You can see this JAMA study from several years ago that probably most of you know, that looked at chloride restrictive strategies and the impact on AKI, where chloride restricted patients did better. They had less AKI with lower serum chlorides. So nephrotoxicity in neurocritical care has been independently associated with both a high sodium, greater than 155, and a high chloride, either 110 or 115, depending on the study you look at. It's not an innocent bystander. We call it hypertonic sodium or hypertonic saline, and we often forget the chloride. Even in my ICU, we check sodiums all the time, but we almost never check a chloride with it. We're more interested in the sodium, the efficacy, but not the safety with the chloride. But it's not an innocent bystander. You can certainly see that serum chloride goes up with a dose of hypertonic saline, which you can see on the graph on the left. And the delta chloride in patients with AKI is much larger. The orange in the AKI group on the right graph is much greater, which shows that patients who start out at a baseline of 105, if you have a small change in chloride, you're much less likely to have AKI than if you have a larger change in chloride. So for safety recommendations, we suggest using osmolar gap over the serum osmolarity threshold. The gap is the best surrogate for mannitol concentration, which is the thing that we know is probably associated best with nephrotoxicity. And then we want to look at upper regions of serum sodium for safety, right around 155, sodium for chloride around 110. But again, very low quality evidence for both of these recommendations. And so we suggest, this is also a recommendation, that severe hypernatremia and hyperthermia should be avoided due to the association with AKI. Right now, that's low quality evidence. So future directions, sodium management, obviously we need a lot of studies. The TBI group had about 70 studies all told, but the rest of them, some of the groups that we looked at really only had 2 or 3 studies that were driving our recommendations. We need to really reevaluate or set a sodium target and study it purposefully. especially with the number of people doing it, as was sort of depicted on your responses today. Is buffered saline the answer for some of this? Possibly using a sodium acetate, sodium bicarb based fluid to reduce the chloride intake may be helpful in some patients. And then there are numerous studies going on looking at biomarkers related to acute kidney injury, related to the safety issues that we just talked about. So just to summarize, and I'd love to take some questions, the clinical impact of ICP and multimodality monitoring is still a bit of a work in progress. I think it's generally accepted that that's something that you would do in a person that you think has elevated intracranial pressure, but the evidence isn't a slam dunk necessarily. There's very little definitive study on this topic for really any of these questions at all, even though it's something that everyone would sort of agree that we should do to give these osmotherapy agents. In general, hypertonic sodium and mannitol are both reasonable to give in neurocritical care patients. And the way that I always say it is give whatever's closest and what you can give fastest, because that's probably the key more than anything else. If you have a chance to make a purposeful selection in TBI and intracerebral hemorrhage, we're weekly recommending hypertonic saline over mannitol. But again, low to very low quality data. It's a very weak or conditional recommendation. And you should always weigh the safety parameters with these targets. We get very bent on these life-threatening situations, worrying about efficacy, and rightly so. But we should also worry about the safety and the collateral damage causing these therapies as well. So that's all I have from the slide set standpoint. I'd love to take any questions or have a discussion about what you guys are seeing or any of our other recommendations that we made in the guidelines. And I very much appreciate your time this evening. Thank you.
Dr. Cook, thank you so much. And yeah, anybody that has any questions, please feel free to type those into the same place you were responding to the questions about sodium goals, or you can try the chat box. We can see both of those. So if anyone has questions, please feel free to type those there and we can start that discussion now. I see a comment, not a question, but thank you. Great talk. Thank you so much. Yeah.
I'll take those too.
Yeah. Last chance for any questions for Dr. Cook. Anybody? Let's see. It looks like someone has. Okay, I see one question. Are you able to see it? See, what are your recommendations for how fast to administer mannitol and HTS?
Great question. Here we go. That's a great question. So it depends on the situation. So I would say if you have someone who's blown a pupil right in front of you and they have a real mechanism for injury, then you need to get it as fast as possible. Squeeze it in, over 5 minutes or so and get it in quick, because now you're sort of at that life-saving stage, and really reducing the amount of time is helpful. The faster you give it, the more you may actually see sort of a transient hypotension with both agents. And so if you can give it over 10-15 minutes by infusion pump, that's great. But you do also have to balance how severe the situation is. Anything longer than probably 30 minutes is probably too long. What you really want is a fast infusion to abruptly change the serum osmolality, to sort of dehydrate the brain and draw that, have those osmotic shifts and draw that fluid. If you're giving it really slowly, then you're not having a lot of those osmotic shifts, and it doesn't help for acute situations. So the next question I see is, would you check osmolar gap before every dose of mannitol? I would say probably an hour or two after. If you check before, then I'm presuming that you're waiting to give it, right? Which doesn't make as much sense necessarily, but you would maybe want to know what the osmolar gap is at some point. So my practice is, if I need it, I give it, And then if I gave it, maybe an hour or two, I check a serum osmolarity in a BMP or Chem7, and I can see what the osmolar gap is. And then that way, in the intervening time period, if I need to give another dose, I'll probably know what those lab values are, and I can make a good decision. Or maybe I shift and use hypertonic saline or something like that. But I don't know that you necessarily need to do it every time, because the osmolar, unless the patient has really poor renal function, the osmolar gap is not going to change that extensively until you've given repeated doses and you've given the chance for the drug to accumulate. This is a drug that is going to be pretty readily filtered. That's why it causes the diuresis. And most of these patients are really sick and they exhibit augmented renal clearance, and they're clearing these drugs really, really fast anyway. And so your concentrations are going to be pretty low. Will you use, my questions thing is really small for some reason, but I'm going to try to pop it out and see if that, yeah, that's good. All right. Oh yeah, there's a lot of questions. Okay. We use, oh, here we go. Is there great literature on combined use of mannitol, hypertonic saline? Not a lot of combined use. Actually, and somebody else asked that too, would you use them both together? I think if you're using them together, maybe you're alternating. Maybe you can mitigate some of the side effects that way. But I don't know that I'm giving them both together, because if you did that, then just double the dose of whichever one you like to use and do it that way. It's going to be the same osmolar load if you double the dose versus give half one, half the other. That is a little similar to what was done in some of the European studies with hetastarch and hypertonic saline, but not quite the same intent. So does my institution require a central line for 3%? Not anymore. There's pretty decent data now on the safety of using 3%, not just for bolus, but also for continuous infusion. If it's a good IV, like an 18 gauge IV, and you rotate the sites every 96 hours or so and monitor that, then generally that plays out pretty well, and the patients tolerate it fine. The phlebitis rate is pretty low, and it's doable. Sort of several references that are available to help support that I think are pretty helpful. In this day and age of not using central lines and having central access, it's really nice to be able to give these hypertonic solutions if you need to without a central line. It's pretty important. When evaluating 23.4% safety as an IV push, what would you like to see? Blood, 23.4% is push. Theoretically, you can give that a little faster because it's lower volume. So I'd like to see sort of a time sequence very finely within the first half hour compared to a 3% or something like that. I guess what I'd like to see is a comparative trial, right? Not just I did it and here's what happened, but I did it and I compared it to patients, similar patients who had 3% bolus or mannitol bolus with an equiosmolar dose. I would like to see finally the blood pressure as well, because I do think you see pretty significant vasodilation with rapid infusion of 23.4%. And so for that reason, we don't, at UK, we don't push it very frequently. We use an infusion pump most of the time for that reason, but and it always makes me worried if you just give somebody 30 mils to push, they may just jam it in, and I've seen some hypotension with that. So that would be probably what I would like to see for a study like that. What osmolar gap threshold do I have? 55 is what's founded in the literature, the best. Some of the more recent clinical trials like PROTECT 3, in their protocol, they used an osmolar gap of 20. But 55 seems to be the threshold where the mannitol concentration is high and associated with nephrotoxicity more than anything else. Let's see, it's a normal system-based regimen that you would use for ICP. Okay, so just, I guess, sort of an empiric dose for ICP. I think that 250 of 3% every so many hours PRN, your ICP goals, a very reasonable way to do it. You know, I think 250 is a pretty good round number. It comes in 500 ml bags for 3%, so that's pretty reasonable. Obviously, you also want some sort of sustained, you know, not a blip of 22, but you've got a good waveform and it's a sustained ICP for more than 5 or 10 minutes, or whatever you all think is appropriate at your institution for what is a sustained ICP. But yeah, that's a great question. I think that's a very reasonable prescription that you wrote there in the questions. It may not be a good question. It probably is. If someone also on Ativan infusion, any tricks to differentiating propylene glycol toxicity from effective hyperosmolar therapy? So that's a good question. A lot of diluents like propylene glycol will also raise your osmolar gap. You may see some more acidosis with that, which, and of course, I mean, you're also going to know the patients on orazepam, and so that would be the issue there. I think if you're having to use both, and you are able to move to something like midazolam or propofol, or, you know, whatever your situation calls for, would be the appropriate sedative. Moving away from orazepam would probably be preferable if you have that option. If not, then and you're, you know, using that much lorazepam where the osmolar gap is going to be high, you probably want to use hypertonic saline as much as you can, so you don't have to worry as much about what the gap is from the mannitol standpoint. Same question about the bicarb in a pinch. Yes, I feel comfortable using it. There's some theoretical advantages to giving a lactate or a chloride salt because of the acidic nature of the salt, just from an oxygen hemoglobin dissociation standpoint. To my knowledge, nobody's really looked into that to that degree with sodium bicarb, but the one big sodium bicarb study that's been published in Neurocritical Care did not show a lot of other electrolyte abnormalities or changes in chloride and bicarb where it was potentially harmful from an acid-base standpoint. Since we know acid-base in these patients can be very complicated as well, with the need to kind of keep their PCO2 down to some degree. So that's a great question. And let's see, when will the hypertonic saline infusion be indicated? It's a great question. That's kind of the crux of that whole targeted versus symptom-based. I'm not sure. If you ask 10 people, probably 9.5 of them will say it's indicated in all these patients, given the goals that were sort of stated here. But it's hard because I think physiologically there's a plausible mechanism for why that would be helpful. But when we try to apply the evidence base to it, it's not. It's just not there right now. Doesn't mean it's not true. Just means that, you know, by the literature we have, we can't have a whole lot of confidence that we know what the answer is at this point. Do you alter based on CRT, dialysate, or rate? CRT in these patients is a whole nother ball game, but yeah, I think, you know, depending on the dialysate that you're using, you are probably going to be thinking about changing the sodium content in those dialysates to where you can avoid hyponatremia for sure, and hopefully avoid giving as much water, free water, as you can, D5 and that sort of thing, just to prevent ICP elevations and that sort of thing. And then do you have a threshold of renal function that you may change mannitol to hypertonic saline? Not specifically. I wouldn't say that I have a serum creatinine necessarily that I would say I don't want to use mannitol in that person. I'm going to use hypertonic saline. I think probably, I guess if I were pressed, I would say if I sort of estimated that their creatinine clearance was 50 or less, I'd start to get worried. But I think we also have to be worried about hyperchloremia as well, right? And so I think the way I used to think was, well, if anybody has nephrotoxicity or poor renal function, I'll just use hypertonic saline and I'll be fine. But now I think we know that that's also not going to be the best thing for the kidneys as well. Maybe that's where buffered saline comes in. especially in those patients with poor renal function. Although the acetate salt also has aluminum in it, so you can't give a whole lot of the acetate salt to patients with really poor renal function because they'll accumulate aluminum, of all things. So it does get to be complicated when you have those patients. And honestly, that's why a lot of the patients who have bad neurologic problems, who have other disease states like the need for CRT or poor renal function, they do really poorly. Partly because these therapies that we're using just don't play well with some of their other comorbidities. It's a great question. So yes, you can definitely. So I don't see a whole lot of other questions. I really appreciate everybody's positive comments, and you can definitely email me questions if you would rather do that or ask my opinion on things or whatever. I'm happy to do that.
I was just going to say,
very
I
much
think we
appreciate
can,
everybody's time.
yeah, we can share some of these questions we maybe weren't able to get to. I can certainly share those with you to get those answered. Thank you so much for taking time to give us this wonderful talk. We appreciate it so much. Also, I don't know if you're on Twitter, but we are on Twitter. So everyone, don't forget, you can continue the conversation there as well. You can check us out at SCCMSE. Got a lot of action going on there with some discussions as well. So always another place to just continue the conversation. So thank you so much. Thanks for joining us. And everyone, please stay safe, and we will see you in November for our next educational meeting.
Thank you.